everyone. Thank you to Shauna for that amazing performance. My name is Andrew Lockhart. I'm a fourth year medical student, one of the vice presidents and head of finance of the Wits Students Physician Society. It is our privilege and honor to host everyone here tonight for our fourth annual Curious Cases event. Joining us tonight, we have a phenomenal panel of speakers who have dedicated their careers to empowering patients and their families and have accomplished many accolades during their times as practitioners. Prof. Dangle, Dr. Kamanga, Dr. Ramela, Dr. Meadows-Taylor, and Ms. Rago, we are very grateful for your support and for dedicating time out of your busy schedules to join us this evening in discussing a few of your most beyond the textbook cases. I would formally like to welcome our partners and esteemed faculty members, Ms. Lydia Makua from the Wits Adler Museum of Medicine, and our patrons, Mr. Koos Kluter, Mrs. Monique Nobrega, Mr. Ricardo Ganesan from the Fed Health Medical Scheme team. Wits Students Physician Society has had the privilege of partnering with Fed Health, who have generously served as our principal sponsors across all our initiatives. Their unwavering support has made it possible for us to host a wide range of academic, professional, and outreach activities, each aimed at enriching the journey of future healthcare professionals. Tonight, as we gather for one of the Society's flagship events, we are especially honored to have Fed Health as our main sponsors once again. Their commitment to empowering students and investing in the future of medicine has been the foundation of our growth and success this year, and we extend our deepest gratitude for their invaluable partnership. Having each of you supporting our event for a second year in a row means very much to our society. From all of us, we thank you for being here. I'll be handing over to Antonia now. Thank you, everyone.
Good evening, fellow students, colleagues, doctors, and esteemed guests. My name is Adunya. I'm a fourth year medical student and have had the privilege of serving as the president of the Wits Students Physician Society for my second year. I stand here with immense gratitude and pride. Over the last year, the Society has continued its growth by hosting successful workshops, outreach initiatives, and events with the purpose of fostering student passion in internal medicine and pediatrics, advancing medical student education, and serving our community. We have successfully maintained our relationships and collaborative partners, namely the Johannesburg Pediatric Colorectal Clinic, SADC, Grace Factory, Teddy Bear Foundation, Trinity Soup Kitchen, school outreaches, the BHCC, the Adler Museum, and various health science departments at FIS through regular clinic volunteering, events, and donation drives. In 2025, we've officially become recognized by the entire university, allowing us to extend our purpose to a larger network of students for a lasting impact. Additionally, we are proud to have launched more specialized workshops, events, and volunteering this year. Notably, our night shift emergency department volunteering in partnership with Helen Joseph Hospital, our research competition called SAMRIC in collaboration with the Undergraduate Journal of Health and the SAMA journals, as well as partnerships with the Johannesburg Children's Home, Childhood Foundation SA, BKMS Africa, the South African Thoracic Society and Allergy Society by assisting in the international conference this year in South Africa, all while still being committed to our studies, which has shaped us to be the doctors we hope to become one day. All our initiatives would have not been possible without the hard work of the executive team and committee. Thank you all for trusting my leadership again and again. We owe the Society's success to everyone's dedication and ongoing commitment. Finally, welcome to our fourth Curious Cases event, an event that started as a small idea with only a few speakers and attendees back when I was in first year, and has grown and expanded to the event we know today. A huge shout out to Raís, who unfortunately could not join us today due to illness, but he's joining online, and the events team for putting together this incredible lineup of speakers and a highly anticipated event at Wits Medical School. I hope you all enjoy this evening. We're just going to go through a few formalities with Daniel, and then we'll start with our first speaker.
Hey guys, I'm not a speaker, I'm just doing some super short housekeeping. First of all, the exit is, surprise surprise, the same as the entrance you came through, so please note that. The emergency exit is that red door over there. The bathroom is upstairs, you passed it on your way in, just take a look to the right in the foyer. Please keep your phones off so the speakers aren't interrupted, and in the same sense, please, if you need to leave, please try your best to leave between talks, not during them. The camera is up there, if you feel like it, please wave, but please don't knock it over, walk in front of it, just be aware of it. And lastly, if you haven't already signed up for our very exciting Tank Scrubs raffle, please do so, the sign-up sheet is outside. Without further ado, I'd like to welcome our first speaker.
Hi everyone, and welcome to Curious Cases. I'm just just going to give a quick overview of how tonight's going to run. So we're first going to introduce every speaker, and then each speaker will take the stand and give their presentation. And then after each presentation, we'll open the floor for a Q&A with the audience. With that in mind, it gives me great pleasure to announce our first speaker, Dr. Noella Kamanga, who is a neonatologist working at the Chris Hani Baragwanath Academic Hospital. She completed her MB-CHB at the University of Cape Town and went on to do the Diploma in Child Health while working in Cape Town. After moving to Johannesburg, she completed the Fellowship of the College of Pediatricians of South Africa, certificates in neonatology while working at the University of the Witwatersrand. Her research topic for her Master's in Science degree was necrotizing enterocolitis. She has a keen interest in this topic and will continue with research in this field. She has lived and worked in South Africa, Tanzania, and Zimbabwe, and is passionate about improving healthcare on the continent. She is currently serving as the GEM4 coordinator and enjoys teaching at an undergraduate and postgraduate level. Can we please give a round of applause to Dr. Kamanga?
Good evening.
Good evening.
Sorry, I thought I'd have a screen in front of me, so I'm going to have to look up there. Sorry about that. But anyway, okay, so I am going to, I'm a bit disorientated. It's been years since I was in an auditorium like this, so please forgive me. We've been doing online lectures for quite a while, so yeah. Okay, so my name is Noella Kamanga, and I'm going to be talking to you about a curious case in neonatology.
Edit the change.
Okay, so I know I've been introduced, but who am I? That's who I am. I'm part of this beautiful family, and as has been said before, we started out in East Africa, came down to Zimbabwe, Cape Town, Johannesburg, back to East Africa, and back to Johannesburg, where we are for now. Okay, I think we're having a bit of sorry. Okay, yeah, thank you. Okay, so I think this has been said already that I studied at UCT and then made my way to Wits. My areas of interest, apart from necrotizing enterocolitis, are breastfeeding and kangaroo mother care. Okay, so why neonatology? So my love for neonatology began in Cape Town when I was working at Mowbray Maternity. So the lady that you see there in the middle, Lucy Lindley, sadly passed away last week actually. She was a neonatologist who started her life out as a midwife. So she was a midwife and became a neonatologist. And her love for neonates was so infectious, the way she would talk to the babies, and the personalities of the babies would actually come through, and you'd see that these are actually human beings. So that's where my love for neonates began, as in my first medical officer job all those years back in the Western Cape. Okay, so what I'm going to do is I'm going to present a case to you, and then I'm going to talk a little bit about the topic at hand. So I'm going to talk to you about little GM, who was a twin, was very, very tiny at birth, 860 grams, and was referred to us at Chris Hani Baragwanath from one of our other secondary level hospitals in Johannesburg. Okay, so the baby was referred to us with a diagnosis of NEC 3B. So just a little bit about the grading of NEC. They grades 1, 2, 3, so 3 being the most severe, and I will come to this a little bit later on. So what you can see from the X-ray that was there. Okay. Pointer. So pointer. No pointer. Oh, okay. Thank you. Okay, can you see that? Okay, so what he had in his X-ray was this very dilated lips of bowel, and if you look here, the bowel has actually perforated. So that was necrotizing enterocolitis 3B. That was severe, and the baby was referred to us for surgical management. Okay, so this little tiny baby actually went through a lot. At the base hospital, a pencil drain was inserted as a temporizing measure, and with us at Chris Hani Baragwana, there were 4 laparotomies that were done. The first one was done on the 12th of December. That was sort of damage control, and then there was another laparotomy, and another laparotomy, and another one, and the final surgical procedure was on the 15th of April, where the ileostomy was reversed. This baby had multiple episodes of sepsis, required ventilation, and of note is that the child was from quite a poor family. These twins were the first, born from the first pregnancy. The father was temporarily employed here and there. Mom was unemployed. They were very poor, but she made a plan to come and visit her baby a few times a week. Because they were twins, she would actually bring the healthy twin to the hospital and park her by the security desk. The security guard would babysit the twin, that was a girl, while she came into the neonatal unit to breastfeed the twin and to bond with the baby. And then he was eventually discharged on the 25th of May after a 5-month stay in hospital. Okay, so today I'm going to talk a little bit about necrotizing enterocolitis. It's the commonest surgical emergency in neonates. Has a high morbidity and a high mortality. So around the world, depending on which cohort that you look at, mortality rates have been reported between 30 and 60%. So this is a very dire condition. And it's characterized by inflammation, ischemia, and necrosis of the intestinal mucosa. The diagnosis is a clinical one, so you see abdominal distension, vomiting. The babies can get quite sick. They can have apneas. They may have hypotension, needing ventilation. And on the X-ray, the confirmation, so you would suspect the diagnosis clinically and confirm the diagnosis on radiographic imaging. So if you look here, you can see that there's these kind of bubbles. Can everyone see that? Yeah, so this is called a soap bubble appearance, or this is called the pneumatosis intestinalis. So this is the bacteria that form gas that sits in the wall of the intestine. And then over here, this is perforated bowel, like we saw in the previous X-ray. Okay, the risk factors, I'm not going to dwell too much, but there are a lot of risk factors. The biggest risk factor is prematurity. So at least 85% of babies who have this condition are premature babies. And the reason why they get this problem is because their gut is immature. And we'll come to that just now. There's also enteral feeding and dysbiosis. Okay, a little bit about the pathophysiology. As I've mentioned, that it's mostly premature babies who get this condition because the gut is immature, so that barrier is not fully developed. So the bacteria can get through. There's microbial dysbiosis, so babies who stay a long time in hospital have an abnormal, or let's say a disturbance of their normal gut flora, because every human being has got what is called normal gut flora. So you have your friendly bugs sitting in your gut. If you're in hospital for a long time, then the bad bacteria kind of overwhelm the good bacteria, to put it simply. There are other factors as well, like genetic predisposition. So these other ones are less well understood. Okay, prevention. So prevention, the main thing is breastfeeding. And August was World Breastfeeding Month, if you didn't know. So breast milk is gold. Gold is like the most amazing thing. So if we can breastfeed these little babies, we can actually save their lives. Antibiotic stewardship and infection prevention. Okay, so this condition is managed by resuscitation. Usually the babies are kept in NILPA-OS for some time. Because they're not eating, they need some kind of nutrition, so that is usually given intravenously. They may need antibiotics. Analgesia is very important because the abdomen is painful, and surgery may be indicated in some of the conditions. Okay, the complications, strictures may form because there's inflammation of the bowel, short bowel syndrome, and intestinal failure associated liver disease, because they may be on parenteral nutrition for quite a long time. And neurodevelopmental delay, as with any other baby who is sick and in hospital and ICU for a long time, their development may not go the way that it's supposed to go. So just a little bit about short bowel syndrome. So short bowel syndrome is basically intestinal failure as a result of anatomic loss of intestinal length. So looking at this diagram, you see the different parts of your gut have different functions. So depending on which, so in this condition of necrotizing enterocolitis, the entire bowel can be affected, but sometimes it is little bits of bowel that are affected. So if it's your upper gastrointestinal tract, such as the duodenum and the ileum, the main problem there is absorption of all your salts and your minerals, and sometimes your vitamins. And then going down into the ileum is your amino acids, vitamins, water, electrolytes as well. And if the colon is affected, then it's the water and electrolytes that are mostly affected. So when surgery is done, depending on the extent of the condition, quite a lot of bowel may have to be cut out. And in some situations, and especially with repeated operations, so much bowel is cut out that the baby is only left with maybe 15 or 20 centimeters of bowel, which is not enough. So there are some situations where so many operations have been done, and then it ends up being a palliative case, because if you have a tiny amount of bowel left, it's actually not compatible with life. So that's just a little bit about short bowel syndrome. Okay, so this is just a little bit of data that we got from our hospital, Chris Hani Baragwana, over 2.5 years. There were 167 babies. So what I wanted to highlight on this slide was that the mean birth weight of these babies is 1,300 grams. So most of them are actually very small babies, premature, 31 weeks. A lot of them ended up having surgery, about 37%, and the mortality rate is my mortality rate? Yeah, the mortality rate is quite high, at 47.9%. So it is a very serious condition. Okay, so what happened to GM? So GM was discharged home on the 25th of April after a 5-month stay in hospital, and was finally reunited with his naughty twin sister, and they are attending neonatal follow-up. So because of everything that he's been through, he was nutritionally quite behind and needed quite a bit of support. So in the state sector, we do have limited resources, but there are a few resources to give such children nutritional support. So in summary, this was a micro-prem who had 4 laparotomies. So having 1 laparotomy puts you at high risk of mortality. Now this little person had 4 laparotomies, and he survived against all odds because of his mother's love. So despite poverty and distance, she made a plan to come and visit her baby, and she was a constant presence in the baby's life and managed to maintain the bond. Okay, so I found this quote by Marion C. Garretti: "A mother's love is the fuel that enables a normal human being to do the impossible." So some of these neonates spent a very long time in hospital. The average stay, I could say, for a premature baby of this size, of 800 grams, a lot of them end up spending 4 or 5 months in hospital, and it's actually very difficult. Some of the moms actually live in the hospital with them for 4 to 6 months. So can you imagine the family dynamics? And something that has been shown over and over again in literature is that if you are a sick person in hospital, you actually do a lot better if you have your loved ones visiting you. So what more of these little neonates? So this was really, when I was asked about, when I asked to do a presentation on a curious case, this case stood out for me because this is somebody so tiny who has undergone 4 operations in and out of ICU, and despite all this, his mom was there at his side every single day, and this was actually very instrumental to his survival. So in conclusion, I'm sure you're going to hear a lot of interesting talks after me. The medical field is vast. I think we have forensics and all these things. So you will find your passion as you go along. My passion is neonatology. And as I mentioned before, this passion started with an encounter that I had with an amazing person. Don't be afraid to try new things, go to new places. As you can see, I've been up and down the continent. Who knows where I'll go next? In the process of being a doctor, don't forget to keep on living. Medicine is not the be-all and end-all. We are more than our field. And my parting phrase is that love is a powerful drug. It has the power to heal, and patients don't read the textbooks. Thank you.
Thank you so much, Dr. Kamanga. Before we continue, does anybody have any questions for the Prof? Yes. Sorry, Prof, just come back.
Thank you for the talk, Prof. I just have a question.
Not a prof yet, but thank you for the office.
Manifesting. In terms of the antibiotic management of NEC, what is your normal course? Is it a week? Is it 2 weeks? And if it's something short-term like that, what was the reason for this patient being in hospital for 5 months? Was it a case of, let's say, bowel being resected and there being a reinfection, or what was or was it a case of resistance? Or?
Okay, thank you for the questions. So in answer to the first question, duration of antibiotics, it's very difficult. It's not hard and fast. It's not fixed. So there are when with the initial presentation with the abdominal distension, vomiting, etc. The patient sometimes is not extremely ill. So in such cases, if it's a mild case, we'll often start empiric antibiotics, we'll do our culture, etc. And if the results are not suggestive and there is clinical improvement, there are situations where it's appropriate to stop antibiotics in 72 hours. If you have a positive culture, then you would have to do at least 7 days of antibiotics. But once again, it depends what bug you grow. If it's a fungal culture, if it's positive for fungus, you would have to do a prolonged course that will usually be about 14 days. Why did this child stay so long in hospital? The reason is that he had advanced disease which needed surgery. So with surgery, the ideal outcome is when they open up and they see a limited disease segment, cut it out, anastomose the bowel, give him time to heal, he feeds, and then he goes home. But in this case, what happened was that there was a patch of necrosis in the duodenum, there was a patch in the colon. There were just patches of dead bowel everywhere. So in that situation, they have to do damage control, cut out whatever dead or necrotic intestine, give it time to heal, and then they have to go back in a few days' time just to see if the disease has extended. If they go back and find that there is no extension, then they can anastomose the bowel and let it heal. But if they go back and they find that there's still active segments, they can't close definitively because they haven't fixed everything. So, post-surgery, it actually takes a long time to start feeding again because, after the surgery, there's inflammation. You have to let that inflammation and the swelling subside, and then start small drops of milk, see if there's toleration of that of the feeds, and then build slowly. And then in between, there are new infections, baby forgets to breathe, goes back to the ventilator, so it's up and down. And remember, these people are born very early. He was born, I think, 2 months too early. So sometimes they actually forget to breathe, and then they have to stay longer in ICU.
I just wanted to ask, so since they were twins, did the other twin, why was one twin more susceptible to developing something like this and had so many more complications than the other twin who seems, according to what you've said, like was healthy and didn't require any, wasn't having complications?
Thank you for that very complicated question. Maybe I'll do that for my PhD. But yeah, so that is one of the things that is very poorly understood. And in necrotizing enterocolitis, there's still a lot of questions, even with the advancement of medicine. So there have been some cases where they think there's a genetic predisposition because twins will get sick at the same time and they will sort of present in a similar way. But there are some, but more often than not, one twin will be completely healthy and the other one will be ill. And they were both treated exactly the same. They were born at the same hospital, same care, everything was the same, but one got sick and the other didn't. We really don't know. And just with the research that we did at our hospital, Chris Hani Baragwanath, there were quite a number of the 167 babies that I mentioned. Quite a few of them were part of twins, and I didn't see twins who both got this illness. The one was healthy and the other one was not. So maybe it's something for you guys to do in your future research as well.
Big thank you to Dr. Kamanga. Next up, another very exciting speaker, Carl.
Good evening once again. Today I have the honor of introducing Dr. Malarata Rumela. Dr. Rumela is one of the 6-member team of all-female doctors at the Diploma Forensic Pathology Service. She obtained a medical degree from the Instituto Superior de Ciencias Médicas, Villa Clara, Cuba, as part of the Nelson Mandela Fidel Castro Scholarship Program. Forensic pathology and cosmetic surgery were the 2 specialties that caught her interest during her undergraduate years, and she eventually decided to pursue forensics pathology as that's what stood out to her. Dr. Rumela has a diploma and a fellowship in forensics pathology from the Colleges of Medicine of South Africa and a Masters of Medicine from Wits University in the same field. Because of curiosity and love for cosmetic surgery, she recently completed her advanced diploma in aesthetic medicine through the Foundation for Professional Development. In her department, she assists with teaching new doctors, giving lectures to both undergraduate medical and law students, and coordinating mobility and mortality meetings with the hospital team services. Currently, she's also serving as the Deputy Chair for the School of Clinical Medicine Transformation Committee. Without further ado, please join me in welcoming Dr. Ramela.
Good evening, everyone. Thank you for this opportunity. I actually quite enjoy doing such talks to young people because I always hope to meet with one or two recruits to join us in the future. Forensic pathology is a very small department. Not many people join us. So we're always keen to recruit more people to come and join the service. So I just thought I'd do a brief overview of what forensic pathology does. So our core function is the medical legal investigation of death. So we only do unnatural cases as defined by the law. So we have 4 categories of unnatural death in South Africa. So the first one is any death from physical or chemical influence and complications thereof. The second one is any death where it would be natural, but because of an act of omission or commission will be deemed unnatural. So those cases are the ones that we call cases of negligence. And then the third category is our procedure-related deaths. They used to be called anesthetic deaths, but then they were amended to procedure-related deaths. The main difference is that with anesthetic deaths, you used to have a time limit. If the person recovers and they regain consciousness, then they would say it's not an anesthetic death. But so with a procedure-related death, there are no time spans. So it can be 6 months or 8 months after that procedure. If you cannot rule out the role of the procedure in the death, it has to come for a medical legal autopsy. And the last category is where death is sudden or unexpected. So young people that are completely healthy and they just drop dead, or where the body is severely decomposed and you cannot just from viewing the body see the cause of death. So we were previously under the South African Police Services until 2006 when we moved to the National Department of Health. There it was because with cases where, for example, police are involved in police brutality, it would be quite difficult to make the investigation independent and objective. So there was a conflict of interest. That's why the decision to move it to the National Department of Health, and that's why we have the IPID to investigate SAPS. We have approximately 121 facilities throughout the country, and in Gauteng we have 11, and we divided into 2 clusters. The northern cluster, where we have Pretoria, Bronkhorstspruit, and Garambua, and in the southern cluster we have 8, and Diepkloof is in one of them, along with Joburg and Germiston. So we do approximately 22,000 autopsies a year, and 18,000 of those are in the southern cluster. In the southern cluster, or in Gauteng, the 3 biggest mortuaries are Germiston, that they do about 4,500 a year. Joburg does just over 4,000, and we do just under 3,000 a year. So Diepkloof services the greater Soweto area and neighboring areas like Eldorado Park and Malaysia. And other functions that we do are research, academics, and preventative through our morbidity and mortality meetings, and also just looking at patterns of injuries in the cases that we get to pick up problem areas in our communities, and obviously giving expert witness in court from what we found in the autopsies. So our day-to-day operations, our forensic pathology officers are the backbone of our service. So they go out to the scenes to pick up the bodies,
then they admit them. At the time of autopsy, they do the evisceration, we dissect the organs and do record all of the injuries. And then they also help the families with identification and releasing the bodies to the families once identified. Unfortunately, there's no formal qualification for forensic pathology officers, so everything is in-house training. Our database is non-electronic, so everything is manual from our death registers to the cases, so it's still very backward. All case files that are admitted, all our case files have to have an SA case 180. That's a document that the subs-official that attends the scene has to complete with the demographics of the deceased, and also they have to state a brief history on the circumstances of death, which they hardly ever do. The most we get is found dead or dead body facing northeast, found lying. How that helps us. And then normally we perform, because we are 6 doctors, we do 3 doctors would perform autopsies on a usual day and would do 4 cases per doctor. And then afterwards you get to type your reports and do teaching or whatever you're assigned for the day. Our after hours duties mainly consist of attending scenes and doing compassionate or religious autopsies. Medical legal versus medical autopsy. I thought I would highlight this because we have, sometimes we have issues with hospitals that admit natural cases that they're still investigating that unfortunately die, and out of curiosity they think they can send it to forensic pathology to do an autopsy. Those kind of cases should actually go to anatomical pathology because it's a natural cause. You just want to say which natural cause there was. Medical legal autopsy, an inquest has to be opened because there's a suspicion of an unnatural death. So in medical autopsies, you have to get consent from the family, and they do at hospitals, they send them to NHLS. Medical legal, we don't need. We are guided by the Inquest Act that gives us the authority to open the body and take whatever we need that will help us with the investigation of it. The usual ancillary investigations that we do are blood alcohol levels, which we do in all of our trauma cases to establish the relationship between trauma and alcohol, which we all saw during COVID. And toxicology, histology, DNA, when needed, sexual assault kit will be collected. CO levels and Lodox for our gunshot cases and our severely decomposed cases. So we do Lodox on all our severely decomposed cases because it can help us to exclude a gunshot when we can't see external injuries. And secondly, for purposes of identification, in case they've done a knee replacement, hip replacement, or they've got an old fracture that we could use for identification. Our day-to-day caseload, mainly gunshots, road traffic accidents, stabbings, sudden unexpected deaths in both children and adults. So the pros and cons of being in forensic, I only see pros. I absolutely love it. I cannot imagine myself waking up to speak to a live patient. So, the pros, we speak for the voiceless to get justice for them. We provide closure to families. Unfortunately, that's not always the case because sometimes in our severely decomposed bodies, or as in the case that I'm going to present, we cannot find the cause of death because sometimes the remains are incomplete or the body is so damaged you cannot make sense of anything there. The psychological trauma, I think sometimes, for example, personally, my biggest issue is with deaths in children, especially avoidable deaths because I always think of my own children. And also where partners kill their own partners, like domestic violence, all of that. Because most of the time, those partners that kill their partners look absolutely normal. They look like phenomenal partners, and then you just cannot make sense of how this person could do such a horrendous deed. And then dealing with the mutilated and severely decomposed bodies, another trauma of mine with decomposed bodies. Our system is very overloaded from SAPS to the justice system. That's why it takes forever for a case to go through the court process. And also it was quite difficult for me to get a case to present because most of our cases are still going through the courts. So this one was one that I could remember that went through the court processes. Critical staff shortages, as I said, we do just under 3,000. Recommended by HPCSA, each doctor should do 250 autopsies a year. We do close to 500 each doctor. And staff shortages in our state labs, so there are huge delays with getting back DNA tests, toxicology tests. So where the death, the cause of death is dependent on toxicology, you can imagine all those estates cannot be wound up. So all the dependents are suffering as we wait for the results to complete the case. So this case that I chose, some might recognize it. It was a few years ago. It was in the media. So these were partial charred remains of a female that was found in a dumping site in the northern suburbs of Gauteng. So at autopsy, what I found was charred remains. Well, that's the history that we got, nothing else. Charred remains found dumped. And at autopsy, charred incomplete remains consisting of a skull, pelvis, and attached lower limbs, and just multiple small fragments of charred bones. Some you could make out, I think, one hand. And there was no neck, no torso. Remnants of clothing, towels, a blood-stained sheet that she was wrapped in, and burnt out tires were observed that were used to obviously generate the fire. So the chief postmortem findings, what I found, which was interesting later when we saw her picture, she had a tuft of chemically treated hair on the vertex of the head. She had burns-related fractures of the head and limbs, and she also had a burns-related epidural hemorrhage. What was also interesting was that you could still see her very fresh pedicure. So the feet were relatively intact, and the genitals, 4th-degree burns, couldn't even identify the internal genitals from the extensive burns. And this case, I referred to anthropology, but because of the extensive damage to the bones that we could find, not much could be done. So the next slides are pretty graphic, but I did send it through, and Carl didn't say anything, so I'm assuming that, everyone will be okay with it. So why I put her picture there, when you look at this, you can still see her prominent cheekbones there. You can still see the nice chin there, and there's the tuft of chemically treated hair that was still intact on her head. And there we had the burns-related fractures that were there. And then it's not very clear on here, but if you could have been able to see the body, in person, what made me conclude that it's a burns-related extradural hemorrhage, apart from the appearance of the extradural hemorrhage. The brain itself there, it did not look like there was damage to it from fractures before death, and you could also see that it had externally, it still had the cooked appearance, and the bones had fragmented on it, so you could still see the burnt bone fragments on it. And then the difference between a pre-mortem and a burns-related epidural hemorrhage. A pre-mortem one is usually associated to a fracture, and most of the time it will be in your frontal temporal areas because of a tear to the anterior meningeal artery. And with a burns-related epidural hemorrhage, it looks like an aero chocolate, so it's got air bubbles trapped inside. That's how you could see, and you'll find it mainly on the over the parietal region. And then on this picture there, those are the hands, what was left of the metacarpal region. And what I could see from there, they were very tiny hands. I think my hands are small, but you know, when I put her hand on mine, it was smaller than mine. We do that often so that you can describe to, you know, estimate stature and everything. You know, we always compare to either a colleague or yourself, you know, the size. So those are the hands there, and they were quite small.
Are we allowed to video this?
Yeah.
Okay. Oh. And then here we have the anterior aspect of what's left of the pelvis and the lower limbs. And there, you won't see it from that far, but you could still see her painted toenails there. And then this is the posterior aspect of the pelvis and the lower limbs there. So these are included because they're very important when it came to trial, because we had to really beef up the circumstances of death because we could not find a definitive cause of death because these were only partial remains. I mean, all the vital organs are in the torso, so you can't even confirm if anything was injured there. And like I said, in the head, we could not find anything that led us to believe that she could have died from trauma. So this sheet was important because when video footage was released, when he actually went to dispose of her, he had wrapped her in this white sheet, which actually was kind of hanging out of the wheelie bin that he was using to go and dispose of her. And also we took the stains there for DNA testing and to see if we could hit anything that would link us to him, because obviously those were hers. And then these were wires from the burnt out tires. There were actually 4 tires around her. So these were some of the wires that we collected from the scene. So the challenge, I chose this case because the challenge is here. When you find a burnt body, besides it detailing the extent of the burns, the type of burns you have, you always have to say whether this person was dead or alive when they suffered the burns. And what we use are your airways. So we look for presence of soot below the larynx. And obviously with the airways gone, we couldn't do that. And then secondly, only minimal blood was could be retrieved. So we got like 2 drops, and personally I have prioritized that for identification because there were no other biological samples. We couldn't use the muscle, it was charred. We couldn't use the bones, they were charred. So we used that for identification, and we obviously got a positive hit from when we compared to her mom. And I wanted to take the epidural hemorrhage to check for CO levels, but unfortunately our labs, our forensic toxicology labs, cannot work with clotted blood, so that was out. In other places we can do that. The cause of death was obviously uncertain, and when I had to go to court, I had to explain all of that to say why the cause of death is uncertain. And obviously they wanted to come with conspiracy theories that obviously I couldn't entertain, because I couldn't say I remember one question was, is it possible that she could have died from a stab wound to the neck? How would I know? There was no neck, you know? So, there's some things that you think, okay, you know, we can't be working on conspiracies because there's another life at stake, especially if someone is falsely accused. So you can't be, you know, creating things, this is possible, anything is possible. She could have been stabbed in the heart, she could have been shot in the abdomen, but unfortunately we don't have that huge portion of the body to be able to determine that. So the circumstances that we recreated from what we found on her, and also there was later testimony that he went to a relative's house to get the same tires that he used to burn her, and acid. So things that we found at the scene helped build the case for us to be able to get a conviction on this case.
Are there any questions regarding the case or forensic pathology from anyone?
So I have two questions. The first is, was the victim's killer ever found?
Yeah, he was convicted. It was the boyfriend.
My second question being a little bit more personal. You mentioned that all training of forensic pathologists is done in-house. How long does that training take?
The officers, not the doctors, the officers that help us. So our supporting staff. So they come about a month or two. We teach them anatomy and how to viscerate and how to divide it, because we viscerate through blocks. We've got the head, we've got the cardiothoracic block, we've got the gastrointestinal block, and then we've got the renal block, urogenital block. So we teach them all of that.
But then shift my question, what is the training to become a forensic pathologist look like?
It's like any other specialty, so you have to do your undergrad and then you take a reg post, 4 to 5 years to specialize.
I wanted to ask, how many rages actually complete their training due to the same pressure like going to court,
Yeah.
or a case like this, like how many can actually cope with that?
Unfortunately, we don't attract a lot of people, and some, yes, do leave, but it's not only the trauma from here, but other frustrations. In our cluster, unfortunately, when I started, there were, I think, a total of 10 people that went through, and I think only 2 of us stuck it through. But others, 2 left and went to completed other areas. So I guess 40%.
I just wanted to ask, you mentioned compassionate and religious autopsies. So what exactly are they and how are they different from
Okay, so religious autopsies are those religions that vary on the same day, like Hindu and Muslim. So we do that occasionally. We have dissidents from the Jewish community. Then compassionate, we do, for example, the hospitals that we service, doctor. They sometimes take very long to complete documents for the bodies to come to us. So you'll find that there's been like a week or 10 days lapse from the time this person has died until they come to us. And let's say it's a Friday and it's a family from the Eastern Cape that has decided to come up. You can't let them stay until Monday to get their bodies. So those are the compassionate ones. Or maybe someone is traveling through the province and is involved in an accident, and when the family hears that they passed away, they just come with their undertaker to come and pick up the body and find that we've got a backlog. So those are the compassionate ones.
So doctor, what's low dox?
It's low dosage X-rays. Yeah.
How do you deal with the, I guess, frustration or kind of inclusivity, like when there's problems with the justice system?
Yeah.
So you presented work that you feel represents a certain something that happened, and then obviously it doesn't really go that way in court.
I tell on them. So usually if I find a case that I feel that this needs to be investigated, like last month I had a neonate where the mom had said this baby was a stillbirth. And then I did the autopsy. This baby had skull fractures, about 3 skull fractures, intracranial hemorrhage, and facial bruising and swelling. And I immediately called the investigating officer and I said that this baby was a live birth and died from head trauma. So you need to go and get this mom's story and take it forward. And when he dilly-dallied, I went to the station commander. So that's what I do. Even prosecutors, where you tell them that this is a serious case, here's the report, please take this seriously, and they don't, I go to the senior prosecutor to tell them, because you can't, especially where there's a child that died and there are other children that are still in that family, you cannot afford to drag your feet, because you must immediately see if there was child abuse, and if there is, those kids need to be removed from the care of those parents. So I tell on them.
Since you work with cases and etc., are you sometimes not scared of maybe getting a threat or just getting a threat? Someone like threatening you or your loved ones?
So far, I've been in forensic for 17 years. There's only one accused that intimidated me, and he absolutely terrified me. And it was a gang-related issue. And when I was testifying, he would look at me, do gestures, and then smile and just do funny things. And I told the investigating officer that this is the issue, and so if you want protection, like if you want to be picked up and then taken there and then back, they do offer that. But there are some cases, especially where I feel that these are very serious cases, where I prefer to drive myself, because long before General Kwanazi, I did not trust subs. So I would drive myself, look for my own accommodation, so that no one knew where I was at any given time, and just pitch in court. Yeah.
Very interesting case. I'm going to hand over to Sarah to introduce our next.
Taylor is a psychiatrist with a special interest in mood and anxiety disorders who is currently working in private practice. She has a particular passion for children and adolescent psychiatry and is the proud mother of 3 daughters. Her training began at the University of the Witwatersrand. Thereafter, she did her internship in community service at Chris Hani Baragwanath Hospital. She followed that with 15 years in clinical forensic pathology and then decided that she wanted to specialize in psychiatry. She did her registrar time at hospitals, including Tara, Barra, Helen Joseph, and Stokefontein Forensic Hospital. Thereafter, she started a subspecialty in child and adolescent psychiatry for 18 months at Rahima Musa Mother and Child Hospital. She decided to move away from government work and into private to allow for greater flexibility, and has been working in her private practice ever since. She works a lot with young women, and particularly children and adolescents, and finds it a huge honor to work with them and to assist them and their families. In her spare time, she loves to garden and is a very amateur dancer and sewer. So let's all welcome Dr. Jess Taylor to the stage.
Thank you very much for having me today. I am an expert in myself. It's been many years since I was here at the Mercury Theatre, so quite privileged to be at this side of the theatre where you guys are. Just to kind of, as a preface to what I have to discuss today, I haven't done the beautiful introductions that my colleagues have done around why I specifically, what I do specifically in psychiatry. But perhaps what is particularly pertinent in the case that we're going to discuss today is that what's interesting is not the diagnosis at the end of the day. So the diagnosis is something that the likelihood that you guys are ever going to see in your lives as clinicians is very slim. It's far more the take-home message around the fact that this is a particularly difficult case because in private we often do tend to work quite an isolated sense. which is quite difficult sometimes. We don't have a very collaborative team. And for those of you who just decide that you want to go and do private work or kind of work independently, I think this is a very important kind of concept to hold on to, which is that we desperately need each other. We desperately need people who've got different ways of looking at things. And the other thing that I think is also very important is for all of those who end up going, or as you all will, into internship and comp service and wage time at the various kind of training hospitals, there is often, or can be, quite a bit of animosity between departments. And it's often because everyone's overloaded and everyone's tired and everyone's trying to serve patients. And, we understand that as it happens, but there are certain situations where we really need each other. I think it's an important thing to remember when you go forward. Okay, so that's just the kind of overview of what we're going to discuss. Okay, so this particular patient that we're going to discuss today, what was important is before she even came to see me, she had some surgical interventions. Okay, and surgical intervention of the specifics that we're going to talk about today was that she had the removal of pituitary adenoma. When she presented to me, she was still is to this day, about 6'4". She actually had kind of basically attained that height by the age of 12. So she had significant growth very early on in her life. And when she was 16, parents, obviously under the guidance of various neurosurgeons, decided that they were going to do surgical removal of the pituitary adenoma. So obviously, for those of you who can remember your anatomy, which I hope you can, essentially the pituitary gland is quite far deep within the brain substance. And usually when we're trying to remove an adenoma, it requires one of two different approaches. So one is what the radioablation, so they use ablative surgical methods, and the other is an actual surgical intervention. So they usually use a transsphenoidal approach, so they basically through the nose and basically very carefully try and dissect the adenoma away from the pituitary gland. Obviously, depending on the size of the adenoma, will decide how much of the actual pituitary and glandular tissue remains after surgery. In the case of my particular patient, not much. Okay, so I just want you to imagine, and I want you to just keep in mind the fact that that adenoma sits, first of all, in a very kind of difficult and tortuous space as far as proximity to different parts of the brain, and specifically towards what we refer to as the limbic system of the brain, the emotional center of the brain. Okay, so this is, I just have to mention this also the preface of this patient, because her case is being written up for a journal. I don't have access to her particular diagrams and her particular scans at the moment, but this is basically, this would be pre-surgery and this is post-surgery. There you can see your adenoma sitting between the sort of testicle, and you can see it sort of on a sagittal section, and this is your coronal section there, post-surgery. So you can see also quite a kind of interesting surgery. You must basically have like nerves of steel to be able to fill around there, but that's why the researchers get paid the money they do. Okay, this is basically just for those of you just a bit of a rehash, the kind of understanding of what the pituitary gland does. Obviously, it's the master kind of hormonal gland of the body, kind of glandular organ of the body. So basically, in this particular instance, what is really important to remember in this case is that in this individual had significant impact on her secondary sexual organs, in particular the functioning of her ovaries. So her hormones became quite dysregulated when they removed a portion of that adenoma. Okay, so this young lady who came to see me, as I said, was a relatively big lady, presented to me in November of 2021. At the time, she was 26 years old. She just attained a master's in industrial engineering. So very, very clever. This is one of those people who had her life, in her ducks in a row. She had basically excelled, basically both at school and at university. She was living independently. She had a very good relationship, stable relationship with a young man who was also an engineer. And she was working for an NGO and basically traveling a large portion of her life. She had been diagnosed, as I said, with double cyst gigantism and pituitary adenoma at the age of 16. Following up with that was obviously surgical removal. And then she remained amenorrheic until the age of 20. I'm not quite sure why they decided to wait that long before they initiated medication, hormones for that matter. But at that point, they initiated her on very, very low doses of combined oral contraceptives. And that's obviously because she wasn't producing enough of her own hormones, so they had to give her some exogenous. Okay. At that point, it was the first time that she, just post-surgery, the first time she ever presented to psychiatry. And in that case, the reason for that was she apparently began some huge changes. So she could describe them as sort of atypical periods of feeling quite low, a little bit depressed, was a bit apathetic. Nothing spectacular. So it wasn't like she presented with these overt features of profound depression. But these episodes generally lasted approximately between 4 to 7 days, and they tended to fluctuate. So sometimes they were 4 days, and there'd be a little bit of a patch, and then there would be another patch of maybe about anything between 4 to 7 days, but very, very irregular. Now, what is very important is that, unlike a lot of us, she was meticulous about recording her mood. And you'll see why this is important when we go on further. But what became so important was that she could literally locate to the day exactly what was happening to her mood, and that became really, really important. So the psychiatrist at the time started her on vortioxetine. Vortioxetine basically is a medication that increases serotonin, noradrenaline, and dopamine, and it does it in a way to try and increase various, to improve various sort of neurocognitive and neurovegetative features of depression. Fortunately, very minimal changes were seen, and at that time, just before she turned the age of 23, suddenly the mood episodes became more frequent. So suddenly they were happening more often, and they were happening slightly more, and they were slightly longer, and they were also much more severe. At that point, the psychiatrist put her on an SSRI and sertraline. So those of you doing psychiatry know what sertraline is, and she was diagnosed with a condition called premenstrual dysphoric disorder. So premenstrual dysphoric disorder is sort of like PMS on steroids. But basically what it is that for a period of time, basically preceding day 1 of the menstrual cycle, there is profound disturbances in mood, often lots of dysphoria, irritability, and low mood. In some instances, even some sort of suicidality and aggression. And if you ever want to read some interesting case studies, look at a case where they use PMDD as a reason for getting off on things like murder charges. Okay, it does exist, and it basically is because the women in that instance become very, very unwell. So she was diagnosed with PMDD, given the sertraline, which we believe is supposed to assist. It's a straightforward premenstrual dysphoric syndrome. Very limited benefit. And what would happen in that instance is, even on the medication, she would have 5 to 8 days where she was fine, and then she would suddenly have 5 to 10 days where she was very, very depressed. At the approximate time, she was seen by the endocrinologist. The endocrinologist added vitamin B6 and increased the dose within her combined oral contraceptive. And then, not soon after that, she was diagnosed with bipolar 2. So what's happening is, each one of the time, every time things are unfitting, they're just moving her into a different category. And this time, they decided on bipolar 2 and started her on lamotrigine. Lamotrigine is a mood stabilizer that works actually as an anti-epileptic. Despite putting her up onto quite high doses of lamotrigine, she didn't have any kind of clear change in her mood. And she often would describe the episodes at that point as literally switching on and switching off. She would have them, and it would get severe, and then literally overnight they would disappear. The additional medication that the trial included things like prepixel, which is a typical antipsychotic, as well as venlafaxine, which is a serotonergic and noradrenergic reuptake inhibitor. So they also generally tend to work quite well in instances where you've got kind of just baseline run-of-the-mill depression and anxiety. What's very important is that at no point did she ever identify any clear manic or hypomanic episodes. So those of you who know psychiatry know you actually can't make formal diagnosis of bipolar if you haven't had any of those. There was no clear decrease in sleep during these episodes, any other episodes, no racing thoughts, no increased libido, no increased appetite, increased bowel-directed activity. Okay, so I'm just going to run through this because obviously the thing about psychiatrists, there's lots of stories and lots to say, and you're not going to run out of time. But basically what's important here is that she had nothing of concern in any of the other features of her examination or history taken. So it's a woman who was really functional, she had a great family, she didn't have any family psychiatric history, she wasn't involved in high-risk behavior, she wasn't taking any substances, she didn't have any anxious or anxiety conditions, there was no clear trauma, she didn't have any heavy trauma at any point. And what was important is that when we took a full ectal history, there was absolutely nothing to indicate she had epilepsy. Okay, so she had nothing to indicate dissociation or perceptual disturbances of any of those things. Okay, so when she came to see me, she was very down. In actual fact, the reason that she came to me was actually because she was completely desperate. None of the medication had worked. At that point, she was having these very variable kind of periods of feeling really down. They were lasting between sort of 6 days to sort of longer. And would happen like clockwork. Every 6 to 11 days, these episodes would last. Duration would be changed from time to time. But the downs were incredibly severe, some of the most severe I've ever seen. But what happened is that almost instantaneously she would get this overwhelming feeling of like foreboding and panic, and then following that with this sense of complete utter dread and depression. She wasn't able to feed herself, she wasn't able to bath herself. Someone who prior to that had been able to function beautifully. She would literally lie on the floor of her apartment, basically not even able to cry because it was so apathetic she couldn't even manage that. It got so severe that we would admit her to hospital, we tried this management. If she was in an episode that was really bad, we tried various kind of interventions, we tried ECT, we did all sorts of things. Nothing seemed to shift this mood at all. And then literally overnight the mood would settle and she'd be back up to being this perfectly functioning human being again. Literally like that. At the time, she became, as I said, very incapacitated to the point that there was often discussion about suicidality. And the suicidality would start when she would start to feel low. So as the feeling would come, the panic over I'm going to be actually lying on the floor, not able to move, was so incapacitating and fearful for her that she literally would say, please, I can't do this anymore. When she was in a good space, there was absolutely no suicidal ideation at all. Neurocognitively, extreme brain fog. So she literally, when she was low, she couldn't think, she couldn't remember, she couldn't even remember her address, her telephone number. It was like her brain took off. She was as a very poor memory, and at times even it would kind of escalate to the forms of deliberate self-harm, just in an episode basically trying to kind of regulate herself, as it were. Okay, important to know that she also suffered from migraines from the age of 17. So 17 is the lucky number here. She had 2 20-minute EEGs basically in the rooms of various neurologists. They found nothing. The gynecological exam, the ovaries were functioning beautifully. Follicles had been visualized, so her body was responding to the exogenous hormones. She had all random hormone levels, which were normal, thyroid was normal, all her baseline blood levels were normal completely. She had 2 MRIs of the brain, both sort of post-surgical removal. The stalk of her pituitary gland was completely normal, so it wasn't like there'd been a regrowth of the adenoma, and there was no hematoma. So that you guys will know that what that is a hematoma is basically just in the case of the pituitary gland, it's basically a growth of secondary tissue, usually post-surgery, which often can cause secondary hormonal difficulties. It's nothing to indicate that at all. Okay, so what did we do? We optimized. I thought, what am I going to do? The first thing I'm going to do is I'm going to optimize her antidepressant, which is what I did. I stopped lamotrigine, which remember is the anti-epileptic, and I stopped flumaxil, which is the antipsychotic. Then over the next 6 months, the episodes suddenly went down, sort of having these episodes only every 2 to 3 months, and they were much less severe, and we thought we were winning. I'm amazing. And then suddenly it stopped working. Literally overnight. Suddenly it wasn't working anymore. The episodes increased then to the pre-increased frequency, so before I even optimized it. It must be the hormone side. We called in the guy and got the endocrinologist and did salivary cortisol and a whole bunch of other tests. They found nothing. Then the guy said, well, let's increase the levels of hormones and of receptors to include more estrogen. We did that. There were 3 changes in the doses. We were winning. It was much better. Suddenly she was okay. I was doing such a brilliant job. Nice clap on the back. And off we go for 6 months. And then suddenly she hits the dips again. And now it's the worst I've ever seen it. Now she's so dysfunctional. She's almost she almost looks like she's catatonic. Incredibly suicidal to the point that you couldn't even get her to. She had to be on, had to review her quite closely, and she was basically moved into a high-risk unit. Her headaches got worse. Her MRI found nothing. Another chest X-ray for review to see why it was. We found nothing. Another EEG for 20 minutes. Found nothing. Blood levels found nothing. Okay, so at this point we're thinking, okay, what do we do? Because now clearly we don't know what we're doing, and all that bravado and ego has just dissipated because we're feeling like we really are rather stupid. We think, well, is it bipolar? Because there's a cyclical nature to it, which is what we often see in bipolar. Only it's an odd thing because she's not responding to meds as she should, and she's deteriorating really fast. Could it be unipolar depression? Why? Because she's never had a manic episode. So is it possible that there's something else here that's pushing it to be sort of what we refer to as unipolar depression? Have we got something else going on in the brain, like this adenoma that we've missed? Or is there some neurological kind of glandular tissue that's moved and grown somewhere else, which there has happened in the past? Do we have some other kind of odd hormonal disturbance that we're not managing to pick up? Or is it possibly that there's another neurological condition? Okay, so at that point, we call in the big guns. And in this case, it's Professor Miller, who's an expert in neurophysiology at the University of Victoria. He has a look at her whole case and he says, I think this has got to do with dopamine and estrogen. There's something happening here with her estrogen levels. And what he did was he changed to oral contraceptive to basically a kind of predominant estrogen-based oral contraceptives, and said to her, you cannot go on the placebos, because unless she would go on the placebos, she would have a big dip. And we thought, you see who went. Because now, what has happened? She was great. Now the mood was stabilized again, and she wasn't depressed. And we felt like we were winning, and no sooner than we were getting excited, then it deteriorated again. So now we are on maximum doses of estrogen. We can't give her any more. And we couldn't understand why it would help work, and suddenly it would deteriorate again. We couldn't do any blood tests to check for dopamine levels, but we tried Ritalin as an alternative to try and optimize dopamine levels. Didn't work at all. And at that point, we said we're going to call in the big guns, and we called a really great, he's a phenomenal neurologist at Mill Park Hospital, Dr. Gora. And Dr. Gora said, after looking for a while, we're going to do an intracranial EEG. So he opened her up in the theatre, put basically electrodes on her brain, and found what we were finding, between dozens of cities, we weren't even looking, we couldn't even look at a handful of cases in the world, is she had what was referred to as a pituitary, sort of a pituitary stalk, onset start pituitary stalk, and basically it's called a hypophyseal seizure. So basically what is happening is from the surgery that happened when she was 16 years old, she was having deep brain seizures that were basically moving through the white matter of the brain and basically disrupting everything. And it was seizures that were not generalized seizures, so she didn't put it around, but she was having significant enough kind of damage to the limbic system of the brain that was basically throwing out her entire emotional network. And as a result, she would become completely utterly depressed. And what would happen is, as she would have these seizures, she would have these periods, and the periods would come almost kind of like clockwork. You know, she would have a seizure, and the seizure would, we're going to talk about it now, would be determined by all sorts of things. But often the seizures was fiddled around with. Okay. So the discussion that we're going to have is about the interaction between epilepsy and estrogen and depression. Okay. So this is basically a very big document to talk about the fact that estrogen is really good for our brain. Okay, for men's brains and for women's brains. But basically what estrogen does is it's really good for preventing and managing depression. So when the estrogen levels drop, what happens is we get depressed. Okay, this is a diagrammatic representation of that. So this is what I was talking about when I was talking about premenstrual dysphoric disorder. Basically what happens is when we sit in a position where our estrogen levels are low, much more dysphoric, much more depressed. Then there's an interaction between estrogen and seizures. Problem is, as you increase estrogen, you increase seizures. Okay, you drop the seizure threshold. So what was happening is we had the sensitive piece of neuronal tissue that had been activated and irritated by the surgery. We were fiddling around with estrogen. Every time we would do that, she would get better. So we would get better because the estrogen was up. And then not soon after, we would push up all these seizures, and the seizures would knock out her mood. So what was happening is we thought we were fixing the problem, and actually that was okay. The other thing that's important to know, is that there is something called catamenial epilepsy, which is what we see often, is that women who've got epilepsy, just before they have, in the luteal phase of their menstrual cycle, they often get much worse. The seizures often become very difficult to manage, basically because of the changes in estrogen and progesterone. This is basically just a diagrammatic representation. I'm sorry, it's not great, but basically, if you were to take this little dot and basically to move it directly in that sort of direction towards the inside of the brain, you would hit the pituitary gland. And as you can see, it's incredibly close to the limbic system and the temporal lobe, which is why, in her case, it was such a disaster, because the proximity of the pituitary gland or the lack of pituitary gland at the surgical site was we were getting ourselves into trouble. She had simple seizures, so she did not have generalized seizures. As a result, we didn't see any kind of changes in level of consciousness, etc. But we definitely saw emotional fallout as a result. Guys, this is, I think it might be a little bit complex for some of you. I hope not, because I'm sure they're not very clear to you. Yeah, but basically what I'm going to say is that epilepsy is associated in its own right with depression. Not only because chronic epilepsy actually causes neuroinflammation within the brain, so that's why people who've had epilepsy for a long time often become more depressed, even outside of the socioeconomic effects of having epilepsy. But what we also know is that in her case in particular, sometimes the epilepsy that moves through certain parts of the brain can disrupt the kind of limbic system and the kind of neurochemicals that are involved in it. What happened with her? Her brain had been entered by surgery. She had what's referred to as intra-ictal mood change. So as a result of the seizure, there was this mood fallout, significant depression. The site of the surgery was very risky because of its proximity to certain parts of the brain. When we introduced the estrogen, we increased seizures, but we made it feel slightly better. Certain medications dropped that seizure threshold, so we actually made the seizures worse. And those were Truanxel, Pixel, and venlafaxine. So I thought we were winning. She was happy for a little bit, and suddenly she deteriorated again. The question is our management of medication sufficient? Was it safe with medication? Because now we've got a woman who's now of childbearing age. She wants to have a baby, but now she's on big doses of anti-epileptics. And you can't take the risk of stopping the anti-epileptics because I think she probably would have killed herself if she had. Okay, so for her, the management going forward, we put her on a new age anti-epileptic drug called Keppra. I don't know if you guys have heard about it. What it does is it inhibits glutamate release, so it prevents excitatory neurochemistry in the brain. It's anti-inflammatory, it obviously prevents seizures, and it decreases neurodegeneration in the brain. So it's a really, really good agent. What makes it particularly good for her is it doesn't interfere with folate levels, which means it's pregnancy safe, pregnancy relatively safe in comparison to the others, and it doesn't interfere with the metabolism of the oral contraceptives. Okay. Side effects are things like brain depression, fatigue. Okay, so the take-home message. Sorry, I'm moving very fast. I put a lot into this talk. If it doesn't fit, don't make it fit. So what tends to happen as clinicians is we take a handful of symptoms and we think, okay, it looks like that must be what it is, and we shove it into that box and hope for it. And that's exactly what all of us did when we were dealing with her case. Logging symptoms is really important. So what helped with us is instead of us thinking, oh, well, this is just a standard bipolar, because it was just so specific, and her timing and dates that she wrote down were so pedantic and so well easy to read, we could be able to see that there was something neurological to the basis. Listen to the finer details. So she was wonderful. She could tell us exactly what happened in her mood and the kind of development of symptoms. Always look for the temporal association. So what did I do before? What happened and why are we dealing with this particular symptom that we've got now? And when indeed you need to front for it.
Thank you so much, Doc. Okay, other than fourth years that just remember they have to start studying neuropsych. Questions, I think?
I wanted to ask, so obviously this is quite an interesting patient, and you said that you moved from state to private. In state, would you have ever caught a patient like this, obviously with all the backlogs and the problems that state has? And two, would you ever have been able to manage a patient like this as well as you guys did, calling in specialists from private hospitals, obviously with all the tests? You said she was put on a new age antidepressant. Would you ever be able to manage a patient like this in the state sector?
It's quite a difficult question, but I think there are probably a lot more cases just like this. Because, one of the things about her was because she was so high functioning, she did have resources. She was able to use this connection of different clinicians, and she would come back regularly. So I think if I was somebody like her and I was unemployed, or I was living in very difficult socioeconomic circumstances, I think I might just get to the point where I just kind of throw my hands up in the air and say, well, I'm depressed, and that's how I'm going to be for the rest of my life. So I think the fact, unfortunately, is that there is a tendency in those socioeconomic institutions to just women better. Possibly because of something like this in government. And I think the problem also in government is that, unfortunately, because of the volume of patients we race through, we don't take that into histories. And that's what all of us did when we were working through registrars.
With regards to management, would you have been able to manage a patient like this?
You know what, I have to say that when the various hospitals that I worked as a consultant, we had some really great multidisciplinary teams. And I think a case like this is a kind of poster child case for what happens when a team works together. I've had similar cases to this, not as significant as this, not as complicated as this, where amazing article. I think that there again it's also about workload. So it's how much available time we've got to kind of focus on case.
Small question about pathophysiology. So, did you ever find out how long seizures lasted and if that had effects in the person who worked for exams or period?
So, Dr. Bora, as I said, I'm sorry I didn't have the photo of what he did, but the problem is obviously, and the reason why none of the other EEGs ever picked it up is because all other kind of pictorial activity gets picked up on the cortex of the brain matter. So, the difficulty there is that none of the other EEGs picked up stuff that was as deep in the brain as the problem is obviously you can't stick around with those paddles in your brain for a long period of time to work out how long. And what I understand, he kind of mapped a lot of the electrical activity with the neurosurgeon for about 40 minutes, and he basically was I'm not so sure. Yeah. Very good question, because not all anti-epileptics are good. The reality is some people's seizures just don't respond to some anti-epileptics do. The other problem is because of the type of seizure that she had, Epilim, Epitech or lamotrigine is a really good anti-epileptic, but it generally doesn't, can often have to use it in conjunction with other epileptics, especially for these very kind of
Doc, you mentioned like you tried everything, you thought it was depression, like severe depression, and as well as bipolar. So I don't know if it relates to this case, but when would you like think of electroconvulsive therapy?
So she did have electroconvulsive therapy. She did have it when she was admitted to hospital. And it was really because of the fact that the team at Dr. Six were just not getting, we haven't moving things. I think this responding to that she was responding to anything. And as I said, so we tried it, didn't have any kind of response. And remember that the understanding behind kind of any kind of ECT or electroconvulsive therapy, so the idea is that you're supposed to reset your brain. So we were kind of hoping that we'd get a bit of respite, mood would improve sort of for periods after ECT waited.
So like, I can't remember what sort of overlap there when you gave the timeline. Was there a reason that her symptoms got so much worse when she turned 23?
Well, this is what we don't know. We're not sure whether it was possibly because of the fact that she had hormones for slightly longer. We're not sure whether, at the time actually, one of the initial neurosurgeons just went in actually did another MRI to see whether it was possible that that had grown again, because they considered that was the reason for the mood. But I think this is what happens with human beings. So she also she only really been on hormones at that for 3 years. So possibly just a control condition.
Thank you so much. Stay in your seats. We've got one more before intermission.
Good evening, everyone. Professor Ziad Dango is the Clinical Research Director at the world-renowned Vaccines and Infectious Disease Analytics Research Unit at the University of the Shire. He also works as a pediatric pulmonologist in the Department of Pediatrics and Child Health at the Chris Hani Baragwanath Academic Hospital. Please join me in giving him a warm welcome.
Good evening, everyone. Thanks very much for the opportunity. I must say that Physician Society is a very organized bunch of people. Compliments to you for having this day. There's a few people staring. Do you want to come and sit? There's some seats in the front. No? Because then, so I've been told that I must come between you and a whole lot of platters of food. So unfortunately, you're going to have to sit through this. And your chairperson says you'll run away after you eat the food. You really need to listen to the story. So let's hope it's worthwhile. You guys don't be happy. So I'm going to tell you a story about the operation. And I've titled this talk Sad Indeed, because I do think this is a sad occurrence that's happened. And I want you to think about why I'm titling this Sad Indeed as I tell you the story. So, giving him a wink, that's my sort of signal. So I'm going to present you Tom. And Tom is a young boy. He was born in 2009, and we saw him roughly in 2020, I think, for the first time. So that makes him about 11 years old, 10, 11 years old. And avid soccer player. Next slide, please. And while playing soccer, and this is the story he tells. He said, while I was playing soccer with my friends after school, I had something in my mouth. And I was actually chewing on the cap of a pen. You know those big pens? Some of you probably still do it, you know. Boring lectures. Who came to my lectures, by the way? Because there's more people here. I'm going to speak to the faculty about moving my lectures to 7 p.m. So anyway, he was chewing on this pen, and as he was playing with the soccer ball, the pen cap disappeared. So that's really, thankfully he didn't choke. And then he went home and he said to his mom, look, I was chewing on my pen cap, and now I'm not chewing on it any longer. And his mom said, I think you should go and look if it comes out, and over the next day or 2 days, just see if something comes out. And he did that. And she said, please record it. Next slide, please. So Tom had a diary, and in his diary he wrote no penny. But he did start coughing a bit, and he was worried that, you know, now he's coughing, and equally his mom was worried. So she took him to a doctor, and the doctor said, interestingly, the doctor said, I'm going to do an X-ray. So the doctor did this X-ray. Who thinks this X-ray is normal? It's unfair to show you this X-ray in your fourth year and expect you to be reporting on this X-ray. But I can tell you, you probably do a better job than the radiologist. But anyway, this doctor looked at this X-ray. And what's concerning about this X-ray, and I don't expect you to know about this right now, but if you can just show them what's concerning with this X-ray, the first thing you'll see is that you don't see the left main bronchus clearly. And the second thing you'll see is that there's something going on in the lower lobe on the left-hand side. But the doctor didn't see that, unfortunately. And he said, okay, look, I don't see the pendant. Now, did you expect him to see the pendant?
No.
No. Okay. He says, I don't see. He said to Mom, look, I don't see. And I want you to go home, and looks like everything's okay. So they went home. And for the rest of that year, saying for the rest of the year, he lost his appetite, started losing weight, and his breath really became bad. He says this as a kid, he tells you that my breath became bad. So, but the thing that bothered Tom the most was his effort endurance and his ability to play his game of soccer was compromised. He didn't have as much energy anymore, but time. That's a big thing. A 10-year-old, 11-year-old telling you, I can't play my soccer anymore for a whole year. So, 15 months later. 15 months later, after that accident, having a cat in his mouth, eventually someone in the family said, look, we're taking you to another doctor. They took him to a pediatrician. It doesn't mean if they took him to a pediatrician, he got better care. It just means they took him to another doctor. And this doctor said, okay, let's do an X-ray. So now clearly there's something wrong on the one side. Okay, there's something wrong on the one side. So they okay, this doctor said, look, I think you need to see a pulmonologist. So they go to Vera. That's where those pulmonologists are. Find them there. So he came. And when he came to Vera, he weighed now 26 kilograms. And this is his sputum. Okay. This is him coughing up into a basin. That's his sputum. So we decided, this is a video, I think it's going to play. No, it didn't play. Okay. And what do we see? Besides that pretty finger. See that cat sitting in his airway. Obviously the cameraman got distracted here because like, oh, so exciting. It shouldn't happen if you're recording something, but anyway, that's the cat. And eventually, you can go to the next slide. We had to get now a rigid bronchoscope. So you get a flexible bronchoscope where you can maneuver around, and you get a rigid bronchoscope, which is this hard metal rod that you put down. And we had to get the surgeon to come and pull this cap out. So next slide. So obviously, this surgeon, we called him Patel and Zanini. They look like this actually. But anyway, they're plumbers, and they came as plumbers to come and remove this piece of. There it is. They removed this pendant. Amazing, eh? So this was Tom, unfortunately, but it's pendant out. Next slide. The next few weeks were not great, obviously, because you saw his X-ray. He was still coughing a lot. Sputum looked really bad, so we gave him some antibiotics. We gave him some chest physio next time. And then what we started seeing is improvement. His coughing became less frequent, less productive. I can come back, he gained 5 kilos in less than a month. So obviously, he was catching up on food, like how you need to go and catch up on some food after this. But the good thing is that you saw an improvement in his X-ray. But is this X-ray normal? Still not normal. That's the unfortunate part. First part you're seeing is now you can see the left main bronchus, but it looks bigger than it should be. Next slide. And then you see this area in the lower lobe. You remember that first X-ray? I'll show it to you again in a few seconds. But that area in the lower lobe is still opacified. Next slide. So this was his X-ray when he first came to us. This was his X-ray a month and a half later. Still not normal. Next slide. So, simple message. Very simple message. I mean, today you heard some profound presentations. Like I kept getting depressed as the presentation. In fact, I had to go out and go get some liquid. It's a heavy presentation. In fact, you should let people eat after the presentation. But this is also another sad story. And why is it sad? Why did I title it sad indeed? It's because we let Tom down, didn't we? We let Tom down because we didn't pay attention to a few things. So let's talk about chewing pens first. And chewing pens, as you know, how many of you did this in school? Come, let's be honest. We are not home. But anyway, interestingly enough, because of this, next slide, they made pens with holes in it. So you know when you got a big pen with it, you'll see the big pen now, big meaning BIC, right? The big pen has a hole on the cap. You know why? Because of this. Because of children putting it in their mouth, and because of the hole, they won't choke now, because now they can breathe through whatever their tiny hole is if they were going to choke. So that's the hole I'm talking about. And they say roughly, roughly 100 people die because of something like crazy. I can't even believe this. Because of the caps. Anyway, that's me. So what I did is I phoned a friend of mine, this Mr. Mots, and I said to him, please ask your school, he's a principal at the school. I said, please ask your kids how many of them actually put things in. But I was curious. And it's just as common as we thought. And you can see that kids do a lot of funny things. How frequently do you reprimand your learner with something in the mouth? And this is he asked the teachers. So other questions we asked about what foreign material they put in the mouth. So now let me show you a little bit more about foreign material. So this is a slide, I don't think it's a video, but anyway, it looks like a plastic device stuck in someone's airway. Next slide. Then it gets exciting. You can see there's caps, there's different types of plastic caps that we've removed. Some look in different sizes, some in different shapes. Next slide. And then you get some funny things like, what the hell is this? Do you know what it is? It's a fun board bloody thing. This child don't think that way. Okay, wait, stop there, stop there. No, next one. Can you see the foreign body here? What is it? Yeah, I said. Next slide. This is where you jump the slide. Here's the spring. Can you see that? Right, there, came out. Next slide. So this is a child. I'll just quickly tell you the story very, very quickly. This is a child who was in the ICU on a ventilator. You can see the ventilator. On the ventilator, complete whiteout on the one side. Oh my God, what's going on? And the intensivists are trying to ventilate this child. They're really struggling. What the hell's going on? And eventually someone decided to go look. Next slide. And you know what they found? They found this thing stuck. Now you say, what the hell is this? You know what this is? Next slide, I'll show you. It's the stupid thing from a cell phone. So that is why the most important message today, is not the most important. Get a cell phone without an aerial. Okay, so then we said, okay, what is the kind of literature out there? So what are people saying about this? So Red Cross Hospital says a lot of children around you can see the age, it's around the 2, 3, 4-year-old. Is that expected? That's a naughty age. Things in your mouth, and play with things. And you can see they found coins, beads, pellets, fish bones, and a whole lot of other things. This was at Red Cross Hospital. So we said, let's do the same thing. And the only reason I showed this slide is to encourage you to do some research. I know some of you have come to me and said, hey, let me do some research. This was an intern who said, let me do some research. And this intern, simple question she asked is, what's the type of foreign bodies that children swallow at our hospital and what ages? And can you see this interesting pattern here? You saw the Red Cross Hospital, much more younger, right? Naughty children. Here in Joburg, much more older naughty children. And boys or girls? Boys. In research, you'll realize the problem with boys are they always get more sick than girls. So they're obviously the weaker of the sexes. And then so different things at our hospital we found nuts, seeds, fruits and vegetables, but you can see the toy parts and the pen and pencil, something that's important, and metal objects, a variety of those. So then we said, okay, is this a problem in South Africa? And obviously it's not a problem in South Africa. You see this all over the world. This is data from Spain. Next slide. And the important thing that you saw in the x-rays, you're not going to see the foreign body. That's why you need to see if the X-ray looks abnormal in a child with chronic symptoms, you need to think about this. And like this thing says, that X-ray will be normal in a number of these cases. Next slide. And the other important message, and this is data from Italy, is that in children, everyone looks on the right-hand side. There's a I'm sure you've heard that before. People tell you if you swallow something, it's going to go down the right-hand side. In children, the right and left main bronchus is not one higher than the other. You can go either way. So right, the problem is people see this and they say, oh no, it's not, the right hand side looks fine, it's not a foreign body. You can go down the left hand side. And if you delay treatment, this is when you get problems. Things are much worse if you delay treatment. I'm not going to harp on this, I know we need to go eat those plants. So let's move on. Even this slide, I think I've said the message. So the concluding points, and I'm not done with my talks. I want to tell you something else. And the thing I want to tell you after the concluding points is, what do you do as a clinician? You're going to say, how would I know there's a foreign body unless someone's going to tell me it's a foreign body? So what do you look out for? How do I sensitize you to this information that you need to take away today? So the concluding points are 1, 2, and 3. You can just go through them. We said, obviously, don't put things in your mouth, and sometimes the x-rays can be normal. But the important thing is a chronic cough. Now, many years I've tried to work out how do I make the registrars and for this matter, you guys as future doctors aware of when to do something. So again, I'm going to say this. How do you know when you need to do something? I mean, it's not fair for me to tell that doctor who missed that foreign body 18 months ago, 15 months ago, that you caused all these problems. Because the doctor may not have got that forthcoming history that the child had swallowed their cat. Or if they did get that information, saw the x-ray and said everything was fine. Next slide. So when you don't identify the problem, you obviously affect the lungs. And the way we affect the lungs is that we cause problems in the airway of the lungs. And this is just a pictorial representation saying that if you had blocked something in the lung by like a foreign body, you prevent the clearance of mucus. So on the right hand side is a normal, what would happen normally? Normally the mucus would go up the escalator and be cleared by your body. You had a peanut in the way, or in this case a cap or a pen, you wouldn't be able to clear the mucus out. But sometimes there are also conditions where there's nothing in the lung, but the escalator doesn't work. Now why I'm showing you this is because I'm trying to make you aware that in all two of these scenarios is that the child is going to present with symptoms. And you need to be aware that it's not just a simple infection that you're treating anymore. There may be an underlying cause. When the doctor first saw this child, he should have said, come back in a month's time. Let me see you again. And then when the child had chronic symptoms, they should have said, okay, there may be an underlying cause for this cough. Next slide. And if you don't treat the underlying cause, I don't expect you to look at this and memorize this, but if you don't treat the underlying cause, you start the cycle of inflammation where you keep producing mucus in your body. Next slide. Now, if you don't treat the cycle of inflammation, you're going to get what happens in this slide. What is happening here? Anybody have an idea of what's happening here? It's obviously something happening in the bronchi. You know what this condition is when your bronchioles become bigger or bronchi become bigger than they should be? Bronchiectasis. So if you don't solve the problem, and that's exactly what Tom's subsequent X-ray shows, is that he's likely to have bronchiectasis in the lung. Now, how do we diagnose bronchiectasis? And the only reason I show the next 3 slides is just for interest. Because at some point in your life, someone's going to say, have you seen the signet ring sign? What the hell does that mean? Okay? This is where it comes from. Children with bronchiectasis, no, they go and back, they're still on the ring. Okay. So for those of you that wear a wedding ring, it's basically a ring that has either the diamond or the pearl on it, and that depicts what normally would be the blood vessel. And the part that your finger goes in depicts what is the bronchus. And as you can see from the CT scan, the bronchus, which is black, is bigger than the vessel. Normally, if you'll remember from anatomy, it's a normal 1:1 ratio. So the first thing you find in bronchiectasis is the bronchi look bigger than the vessel. That's how we know it's bronchiectasis. So in Tom's case, if you did a CT scan, that's what you find, and the radiologist will say, I see the signet inside, and all they mean, they see that. Sometimes, next slide, the radiologist will say, I see tram tracking. And again, like I said, I show you these slides just so that when these words come out in the next few years, you know what they're talking about. Do you know, most people have not seen these pictures before. The users went, oh my God, there's signet ring. Everyone like, what the hell are signet rings? Because no one knows. Similarly, they'll say, the radiologist, there's tram tracking in the lung. What is tram tracking? Essentially, it's just this representation of a railway line. And again, it's suggesting that there's mucus in the airway. Next slide. And then you'll hear this one. This one, radiologists love at the moment. There's a 3-in-1 sign. That is a 3-in-1. All they're doing is they're looking at this. It looks like a flower with a bud on the end. They call it a 3-in-1 sign. So I thought I'll show you. Fine. Next slide. So, how do you manage a child who's not responding to therapy? And if you look at the South African treatment guidelines for pneumonia in children, they have a statement that says, stop. Okay, so what it does, it says, when a child's not responding, next slide, you need to do something. And we wrote this paper because it was irritating me. It was irritating me that you were missing these kind of cases. And we wrote this paper with the intent of sharing this information with 2 very senior pulmonologists. The one is from Cape Town, Professor Heather, the other one is Professor Ian Chen from Australia, talking about the child with the chronic cough and when do you do something about it. Because as clinicians, you'll see them and you'll call them a lower respiratory tract infection. And the next slide is probably the most important one. The next slide, the most important part is, next slide. Next slide. Is this point. He said most children, if they had a lower respiratory tract infection, will get better. And if they're not getting better, there's something. So I'll end with this last slide, which is the next slide. Is how do you know who to target for more investigations? How do you know when to look more deeply into the problem? And I want you to think of spur. One more. One more. One more. This happens when you don't control your own style. Spur stands for severe, so it means that the presentation was severe. P stands for persistent, means that it did not want to get better. U stands for unusual, meaning it is unusual organisms, unusual presentation. And R stands for recurrent. The child keeps coming back. If I can leave you with just one message, besides the fact that don't put pen lids in your mouth, is that when you as a doctor are faced with a child who has spur, you need to start thinking about other problems. That's what's depicted in Tom's situation, is that there's an underlying problem that is not being addressed. Because it's not being addressed, damaging his lungs. Thank you for your attention.
Thank you, Prof. That was an incredible talk. Are there any questions for Prof?
If Tom stand up and soccer again? Yes, because he's passionate. I don't know how good he is, but.
Any other questions besides Tom's soccer? There's one more announcement from Ashley, and then we go eat, and she's going to leave after. But Ashley will just share something.
So that brings us to our refreshments break, finally, yay, everyone. And if I can just ask you all to stretch your legs, go upstairs, get some refreshments, and chat to our guests. That'll be lovely.
Can the doctor just please
Yes.
please be first, so we can do first,
And then we'll release all the students to go there.
as many subjects, and her South African Institute of Chartered Accountants articles. Ms. Rago joined MedScheme in 2007, fulfilling numerous roles within the business, including internal audit, finance, and governance roles along the way. With this, she has built up a knowledge base in the healthcare industry coupled with systems and quality management skills. She has been in healthcare forensics department since 2022 and sees the other side of healthcare, the naughty one. If you can please join me in welcoming her.
Good evening, everyone. Thank you for the opportunity to be here, especially as a Wits graduate. I was down the road in the accounting building, so this is all new to me, but I guess we all are Wits people, eh? No offense in advance to any of the doctors here, but my name is Desiree. I am from MedScheme. We are a medical aid administrator, and one of the schemes that we administer is Pet Health. I work specifically in the forensics department, and yes, budding doctors. We do see fraud in the healthcare industry, and I'm going to share some interesting stories with you on it. Okay, I think we'll start off with a video just to give you a quick introduction of what FWA is. Nothing?
Not working, sorry.
Okay, so just something on the forensics team. So we are within the Afrocentric group, and our team consists of 72 staff. We are the biggest team in South Africa and the biggest team in Africa. We have over 472 years of forensics experience within our team, over 1,000 years of healthcare experience. Collectively, we have over 186 qualifications. So we need all of this experience and all of this qualifications to work on the fraud, waste, and abuse that we see in the industry. We have, for example, a medical doctor who will intervene on investigations on healthcare providers, where she will check the actual billing that a doctor would do, the codes that they would use. We have lawyers within our team because we actually take some of our cases and confirm fraudulent cases through to SAPS. We lay criminal charges against doctors if we have confirmed fraud that we find. We have nurses, we have pediatricians, we have people who work in EMS, we have optometrists. They all assist us in all of the various doctors and all of the various fields that we look at within healthcare fraud. So let's start off by going through what is fraud, waste, and abuse. And over the last 2 years or so, we've actually added the word error as well, because we do see error sometimes. So fraud is where a doctor would knowingly submit fraudulent claims or misrepresent facts to a medical scheme. Now, as you know, we deal mostly with the private medical schemes, for example, a Fed Health, a Bonitas. So we see all of the claims that come in. Some of the examples of fraud that we see is where a doctor will submit claims of, for example, 20 claims for the day, when in actual fact he has actually consulted maybe 10 patients. Also, we have audiologists who would dispense hearing aids as an example. Now, a hearing aid could go up to maybe 15,000 Rand. You'd find someone who does not need a hearing aid, and you have claims being submitted to the medical scheme where apparently the patient is receiving a hearing aid when they don't. What happens is that the doctor receives payment for that hearing aid, and then that money is split between the doctor and the member. The waste that we have is where we see the overuse of services. There, for example, you would find that you'd have a patient going through to the general practitioner just to treat a mild case of the flu, but then you'd have the doctor ordering blood tests or ordering x-rays, which is not really needed. Abuse, there you'd find a general practitioner, for example,
when you treat the case of flu, which can be done in one consultation, you find them asking for the patients or the members to come back for 2 or 3 consults thereafter. And in terms of error, well, when you qualified, you might have practice managers who actually submit your claims through to the medical scheme for payment. You could find that they make administration errors, which we do accept, and we ask them to pay the money back to the scheme, and then we continue. So in terms of looking at fraud, we have 3 components when we look at fraud within the industry. There needs to be the incentive or pressure, the opportunity, and the rationalization. These are the examples I'm going to talk about is actual conversations that we've had with healthcare practitioners or even the members at some point. In terms of incentive, so you find okay, let me start with opportunity. You have doctors who, by their nature, they don't feel anything of it to submit fraudulent claim. So the opportunity you have is that the doctor will submit fraudulent claims. You'll also have a member who will accept a fraudulent claim on their medical aid statement, for example, and that's where you have your opportunity to commit fraud. The rationalization, when you speak to some of the members, they say, and we all know medical aid is a grudge purchase. They say to us, but I pay my medical aid contributions annually. I don't use all of the benefits, and I want to have the maximum benefit, so it's okay for the doctor to submit fraudulent claims. I can get my kickback, so it's fine. I'm happy with fraudulent claims being submitted. In terms of incentives and pressure, we all know the financial situation we are in our country. We have members who are on the lower end of the salary scales, and where they have pressure, they would sometimes say to us, but if I have to receive a kickback from the doctor for this fraudulent claim that they've submitted on my medical aid, it makes a difference to me paying school fees, paying creche fees, or even paying for transport for my children. So if you have any one of those components there in the fraud triangle, then we find that there is opportunity for fraud. In terms of what we do within our space, so we will get a complaint of fraud. We have members who will call into our independent fraud lines that we have. You have a member calling in to say, I've noted this claim on my statement. I do not see that doctor on that date. Please, can you investigate? We will then engage with the healthcare practitioner. We will ask them to give us patient records so that we can match patient records back to the claims that we see submitted on the medical scheme so that we can validate claims. Most of the cases that we find, you cannot validate claims, and there you find that you actually have fraudulent claims. In addition to fraudulent claims, you also have instances of upcoding. If I could use an example there, when you have a psychiatrist, no offense, doc, where you have a consultation for an hour. So psychiatrists normally will put time-based consultations. You can have a consultation for 30 minutes, but you find the claims coming in for consultations for 60 minutes or even 90 minutes. You also have theatre costs coming through. Instead of the doctor charging for maybe 3 needles, for example, that they would use, I am not a medical person, please. You'd find them actually charging us for 10 needles. So it's excessive consumables as an example that they would use. So based on our investigations, we can, as I've mentioned, when we are done with the investigation, we will quantify and say, dear doctor, we have found fraud or waste or abuse to this value for the schemes that we administer. Please pay that money back to the schemes. The impact of this fraud on the industry, it is driving up the healthcare costs. That is why you hear of people on medical aids complaining of how expensive medical aids are. Remember, the more fraud you have, the medical aid is going to increase contributions to be able to recoup that money to obviously still stay in operation, to have medical aid members and to provide the services as well. So that is what the doctors don't see. They find the opportunity to submit fraudulent claims or to have waste and abuse, and they don't realize what they actually do and the cost that it has on the schemes and the members itself. If we find that the fraud is severe enough, we can and we lodge SACS cases. We will have evidence to show the investigating officers of the fraud that has been committed. We also have some of these HCPs sitting in court, and some of these have gone to trial. We also, depending on the nature of the investigations, we will report these providers through to Healthcare Professional Council. They take you to an inquiry, and they can actually, depending on what the outcome of those cases are, they fine you in terms of a monetary value, or they can suspend you from practicing for a period of a couple of months and even years. They can also suspend you and then you lose your HBCSA number. If you are a social worker, for example, we can also report you to the Social Worker Society. Different disciplines have different societies that support them, so we also report you to the relevant societies as well. When we investigate providers, we will always watch their behavior going forward. So if you do happen to get investigated by us, you will not escape us. You will always be on our radar, and we'll always see if you have changed your behavior. What we also do for the schemes as well, we try and be proactive. So opportunities like this, for example, where we can spread the word about fraud awareness, and we teach our members, look at your statements. This is how you identify fraud. Please come forward and please report the fraud so that we can fight the fraud together with the member. So these are some of the stories, real life stories that we see. The mushroom is the most apt picture I could put. This was a psychiatrist who was submitting claims to our schemes for services not rendered. So when we engaged with the psychiatrist, he was actually giving out magic mushrooms to his members. Obviously, there's no code for magic mushrooms in any of the tarot codes that you see for any medical scheme. But what he did is he put them through as consultations, but you can see what he was actually giving his members. When we engaged with him and we asked him, please can you give us patient records so that we could see what he was billing, his response to us is that he does not want to give us any of his records unless we paid him for his records, which actually they ensured us that it was actually false claims, and he was going to go and generate those records, and he was going to send them to us. On the next one, this is a nurse that we investigated. I think it was in Boxburg. So what she had done, she had a runner. These runners used to go and collect medical aid cards in the street that she operated from. She used to submit claims through to the medical aids, and they used to all get a portion of the claims that used to be paid. And we could see that claims were coming through from all the provinces. And when you look at the registered address, it is based in Gauteng. How did we get to know about this investigation? She did not give the correct portion to one of the members. That same member who was receiving a portion of those false claims called into our independent hotlines and reported the nurse herself. So they report their own wrong. So we also, besides the whistleblower reports that we receive to have investigations, we also, as a medical aid administrator, we receive all the claims for payment. So we will analyze claims. We can see for a specific doctor where there is excessive use, for example, where there is outliers. Through our analytical tools, it will tell us, okay, go and investigate a certain doctor because this is what we see. This is a dentist that we investigated. You can see the number of fillings from the little description I put there. He had excessive number of fillings. And when we asked him why so many fillings that he does in a day, because you know you can only do so many fillings on a patient on a day. His response to us is that he has a passion for fillings, and that's why he does so many fillings. As I look at the dentist, another dentist that we investigated, in dentistry, you'll know that every tooth has a number. We picked up claims where the tooth was extracted last year, but we received claims this year for fillings being done on the extracted tooth. I think you know the order. So as I mentioned, this is what we do to get our message out there. We try and educate the members when we speak to the healthcare providers, when we do investigations. Our first, the best outcome for us from all of these investigations is to actually get the doctor to rehabilitate from their wrongdoings. We do see that we have healthcare providers that we do one investigation on and then their claims are fine thereafter. But we actually see some of them where we do 2 or 3 audits thereafter, which just goes to show that they don't learn from what we've engaged them on, and they just don't care. They continue committing fraud, and they think that it's fine to do that. We will, besides actually engaging with the healthcare professionals, we would want to speak to our members out there, because our members, first and foremost, is who we want to take care of. And the more we educate them on looking out for fraudulent claims, or even listening to someone having a conversation around them, you'd find maybe a relative saying, go to this pharmacy, they will put through these claims, and then you can get maybe shampoos or conditioners or something like that. And you find those hotlines actually coming through. And hotlines are the main drivers that we have, some of the cases that we do out there. I'm hoping this video plays, but if it doesn't, nothing. Okay, and I think just to end off, good luck with your studies. You know how hard you are working to get the qualification, the time that you're putting in, the effort that you're putting in. Please do not give your registration number to anyone out there to use to submit claims. You will be caught, and your registration number is then in jeopardy. And lastly, I do not want to investigate any of you. Please, I am going to remember all of your faces, but this is what we do. That's why in my bio you would have seen, I see the other side, the naughty side. You do have genuine healthcare practitioners who care for their patients, who care about what they do. But on the other side, and what I see is those who don't care. They don't feel anything about actually putting in those false claims. They actually come into engagements with us. They justify what they do, which we sometimes cannot believe. So I get to see the other side, and I hope I don't see you on the other side as well. Thank you.
Thank you very much for that interesting talk. Do you have any questions? Yeah.
I want to answer you what the bad side. I want to ask what extent you guys trust that what the doctors are doing is correct and doing it right by the patient. And after that, like, what is the process that you guys deny claims, deny procedures that need to be done at the doctor gives?
So like you said, there is a trust element. So we have trust in that if we have to identify an instance of fraud and if we are investigating you, that when you do sit with us, for example, or when you give us patient files, that you're giving us the truth for us to look at. We do have the skill and experience to pick up when you are lying as a healthcare practitioner. We've seen instances of records where you can physically see Tipex, you can see where dates have been manipulated. So that is how we pick up when something is wrong. And if we do find, and if we do find confirmed instances of fraud, we do then follow the case through to say, we have these issues noted, this is what we quantify you on, please pay that money back. But you do have some providers who will come sit in a meeting and say, yes, I admit I have made an error. in that case, we will still quantify, we will still recover the money, and then we move on from there.
Yes.
Yeah, just wanted to add to the question. Your question related to the diagnosis, also. So it's about, like, for example, if someone comes in with a you might suspect that this patient wants to order that checks X-ray. You know, you guys might not necessarily understand that. So you guys can answer that, or
So in that case, in that case, so our medical doctor, as an example, so that's what we call following the member or following the patient. We can see from the claims that come in whether it warrants going for that blood test or that X-ray, because you would have other associated claims that would come through from there, and then you can see was tests that were needed and that they should have been ordered for it. Some of the instances where we find where you need to go see a specialist, you have to have a referral from a GP as an example, and then you go to see a specialist. When we are investigating the specialist, we will ask the specialist who is the referring doctor, and give us the referral letters. They will give us all the GP letters. When we follow that GP and go and look at the claims, we see that there's no claim from the GP, but yet we have a letter from a GP saying, I am referring this person through to the specialist, which shows that the GP and the specialist are colluding with each other and submitting those claims.
But not always. Sometimes, for example, as colleagues, we can see each other's system. I consult, like with my ENT, I don't pay.
you don't submit the claim to the meeting there.
No, like,
Yeah.
he saw me, but referred me to an ultrasound because I needed a test and possible hearing aid. But he didn't claim from my medical aid, but I went to see those levels.
But if
that would be the referring doctor.
Correct, but if you, in our instance, the volume or the sample of files that we would see, it would not be possible that everybody would just go to a friend and speak to them and not submit consultation through as well. So we will be able to pick it up some way or the other that fraudulent claims have come through. Because we don't just maybe look at one or two. We can go up to 20 patient files, even 30 patient files in an investigation.
I think the key thing is to remember lots of doctors sitting on the other side as well. So that if there is diagnosis and if things look suspect, there's another talk about coding and how to code and what to code and what diagnosis code and needs to use as well. So if those type of things doesn't tie up, for example, sometimes happen is that has to be the head discovery, they will charge for a food. They'll put a code down for your food. Automatically the system will say, hey, what other thing? Yeah. Because the things doesn't tie up. That's in love. And those are the things that the system will pick up. Once it's diagnosed.
Okay, thank you very much. Okay, we're now going to move on to the scrub raffle. So here we have it.
Exciting part now. Before we get off, I just want to say, for like an event of this magnitude is really dependent on how good your sponsor is. So we'd like to extend a very good thanks to Fed Health for working with our society, as well as to Scrub Labs and to Tank for supporting our society and supporting our mission throughout the years. It's such an honor to work with these organizations. We're going to be drawing 3 names. So I'm going to call on Mr. Kurt Kluter to assist in the draw. Come down because we want to take a photo.
Fun. Second up is John Alameka. Okay, and the last one is Lornell Swart.
One more round of applause for our sponsors of the event. Okay, now before we conclude, we'd just like to thank everyone for the attendance and support, not only for tonight's event, but throughout the year. And we hope that you guys enjoyed this event as well.
In his absence, Ray East, the Society's head of events and one of the serving VPs, has asked us to share a message on his behalf. Firstly, a huge congratulations to the Curious Case and events team for their exceptional and hard work to make these projects come to life despite juggling a plethora of other commitments. This event continues to serve as a real highlight for the Society every year, and we are very thankful for our guest speakers, university and faculty members, Fed Health Medical Scheme, and our community at medical school for supporting the Wits Students Physician Society.
Next, I'd like to thank Antonia and Henry and share a few words on behalf of Ray East himself. And I quote, Antonia has been a rock of mine on the Society and throughout my med school journey thus far. Now, it is both her and Henry's last year on the Society. I would just like to highlight that she was a first-year student on the Society when this event was first launched, and she has not only witnessed, but has been one of the biggest contributors alongside our fantastic event team to the growth the Society has achieved across the years. Thank you very much for creating the first environment we know and love. And on another special note, equally as special, I would like to add, it is her birthday tomorrow. So as I'm reading this, I hope she's feeling very nostalgic and is taking it all in. Now that's a cause for celebration.
Thank Burton Rees, Henry, who has been an incredible right-hand man since his day one of joining the Society. He works diligently and relentlessly to achieve any task laid out in front of him, and does so with the utmost respect and steadiness. I'm incredibly grateful to have served as a VP alongside you, Henry, and you have truly inspired me to work that much harder to bring plans to action. Thank you for your support. It's also Henry's birthday next week. Shout out to him. On behalf of the Society, and I can only do this because Rais isn't here, we would like to thank Rais, who's our head of events. Rais is firmly set in the foundation of every single FISOC event. He's behind the scenes sending emails, arranging venues, setting up. You can name any task that's involved in planning an event, and Rais is involved in some way with it. If you've ever ran your own event as a Society member, you know that at any point you can look over your shoulder and Rais is there, he's cheering you on, and he's also picking up all of the balls that you dropped on your way going through. So on behalf of the Society, I would like to thank Rais for all the work he has done, not just this evening, but throughout the year to make all of the amazing events that FISOC has run happen. A huge congratulations to our phenomenal exec team who has worked tirelessly this year to grow our initiatives and start new ones. The whole committee can agree that it has been a privilege to work under your leadership.
Now, before we wish everyone a safe trip home, we'd like to remind everyone of the Art for Mental Health exhibition that is set for October. If you'd like to submit an artwork for this exhibition, being hosted in collaboration with the Wits Department of Psychiatry and the Wits at the Museum, please check out our social media for more information. And note that the deadline is the end of September. But it does not end there. We have more exciting and specialized workshops lined up for the rest of the year, so please keep your eye out for that as well. Additionally, the winners of the South African Undergraduate Medical Research Competition in conjunction with UCT and the Undergraduate Research and Health Journal will be announced in October. And before you go darting off, please feel free to check out the FedHealth store on your way out.
Continue to support the Care Kit Drive. You can find these donation boxes at the entrance of the Med School Library. Thank you, everyone. Have a safe journey home, and we look forward to engaging with everyone at our upcoming projects. Can our speakers also just stay behind for a small picture, and then we have a little token of our appreciation from the society. Thank you so much, everyone.